Before you agree to a prostate biopsy, you need two things. Because biopsy isn't just a test, it can save your life or it can change it forever. I'm Dr. Kovanets, I'm an oncologist, and today I'm explaining a biopsy trap and the two questions that protect you from unnecessary procedures and unnecessary treatments. Let me be very clear, biopsies can save lives. And a lot of times, biopsy is the exactly right step. The problem is when biopsy becomes an automatic reflex based on one single PSA test, without repeating PSA and without using modern tools we use today. That's the trap. The traditional biopsy has often been a systematic approach, multiple needle samples, 10 to 12, taken from different regions of prostate, hoping to hit the cancer lesion. It's basically a medical version of battleship, sampling zones, hoping you hit the spot. And here's the problem with battleship medicine. A systematic blind biopsy can do two harmful things. It can find a tiny low-risk cancer that would never have hurt you and trigger panic and overtreatment. And it can also miss an important cancer, so-called false negative, simply because the needle didn't hit the right spot. That's called sampling error. So biopsy is not a simple yes or no. How you do it and how you aim intelligently really matters. Now the biopsies can also have physical downsides, bleeding, infection, and pain depending on the approach. Many biopsies are transrectal, that means going through the rectum, bringing significant risk of infections. Some centers use transperineal biopsy, that means going through the skin, which brings low risk of infection. But the big message today is do not let biopsy to be the first reflex. Here's the part most men are not told today. Not all prostate cancers are dangerous. Many of them are slow growing, may never cause symptoms, or shorten your life. Guidelines emphasize that before biopsy, men should understand that they could discover the low-risk prostate cancer that are not harmful. Such cancers carry very low risk of mortality, and not every detected cancer like this needs aggressive treatment. And this is where the trap snaps shut. Once you hear the word cancer, the psychology takes over. Even if it's low risk, men understandably want it destroyed. That can lead to overtreatment, radiotherapy, or surgery for a disease that could have been watched, resulting in permanent side effects like erectile dysfunction or urinary leakage. So the trap looks like this: high PSA, reflex biopsy, low-risk cancer found, panic followed by aggressive treatment, and then lifelong side effects. So what should happen when PSA is elevated? The keyword is sequence. Step 1, if PSA is newly elevated, repeat it. Before biomarkers, imaging, or biopsy, repeating a newly elevated PSA is recommended. Because PSA can rise for many non-cancer causes, and one repeat test can prevent a cascade of unnecessary procedures. If PSA stays concerning, now we use modern tools to avoid guessing. Escape route number 1 is MRI before biopsy. We talked about this before. A high-quality MRI can show us whether there is a suspicious lesion in the prostate and where it is located. Guidelines support using MRI before biopsy to improve the detection of clinically significant disease. If MRI is negative, it does not guarantee no cancer, but it helps you and your doctor decide whether biopsy is necessary depending on overall risk. And this directly addresses the problem of false negatives. Targeting reduces the chances you will miss the cancer lesion compared to pure guessing. Escape route number 2 are biomarkers, but biomarkers are not for everyone. Biomarkers are the signs of cancer you can find in blood or urine, and you can use them selectively if this would help the decision about the biopsy. These are not strict cancer tests. Think of them as calculators you can find in your blood, in your urine, where you calculate the risk. and this is the estimation of possibly clinically significant cancer. They're most helpful if you are truly undecided, when the result could push you toward doing the biopsy now versus monitoring and reassessing. Escape route number 3 are risk calculators. We have validated risk calculators using PSA, age, family history, digital rectal examination findings, prior results, sometimes MRI to estimate the risk and support shared decision making. In real life, the good decision making often looks like repeat PSA, assess overall risk, MRI, optimal biomarkers if decision changing, and decide on biopsy. That's how you avoid the trap. If a doctor sees a PSA result and schedules immediate biopsy, just ask to pause the conveyor belt. Ask these 2 questions. Can we repeat the PSA? And if we are still unsure, can we use supplementary biomarkers or risk calculators? And should we do a prostate MRI so we know that there is a target? And whether the targeted biopsy makes more sense than just guessing with a blind one? A high PSA is not automatically an emergency, and it does not warrant immediate biopsy. Sometimes biopsy is exactly the right move, but do it in a modern sequence. Repeat PSA, use MRI and risk tools, and biopsy intelligently. And remember, negative biopsy does not automatically mean you are done, because false negatives happen. Guidance is clear: you should not discontinue screening or follow-up because of the negative biopsy. And decisions should be made based on overall risk, not just one result. For example, a man with a PSA of 6 but a completely clear MRI and low-risk biomarker score is in a very different situation than a man with a PSA of 6 and a highly suspicious MRI target. The single number alone doesn't tell the whole story. The combination of these modern tools does. And if you want something practical, I made a 14-page PSA guide. Everything in it is free in my videos. The guide just organizes it. Inside, I break down the exact sequences of tests we just talked about, explain how to read your specific lab results, and give you a printable checklist or questions to bring to your urologist. You don't have to memorize everything in this video. The guide gives you the exact blueprint. It's paid optional guide link below. If this video gave you clarity, please like and subscribe. We are building a channel where we educate men about health. I'm Dr. Chovanec, I'm a medical oncologist, and I'll see you in my next video.